in 2012 by releasing a set of educational DVDs by none other than Dr. Sion and Kim. In Jan 2012, then he visited our place in Kollam near Trivandrum. Till July, we were having contact classes, training programs, and certificate courses in our place. Because of the COVID, we started the online training programs. And the logo was released by none other than Professor Palanivelu.
Thank you, sir. Now I welcome Dr. Palanivelu, sir, Chairman, GEM Group of Hospitals and Research Center, and the Founder President, MSc, for releasing the logo of SENADHIPAN Education Foundation and for the inaugural address. Over to you, sir.
Thank you, Nisha, and thank you, Baiju, for inviting me to be here.
After that, we had almost 20 webinars we conducted at 8 o'clock all Sundays. And we started streaming live surgeries. So in a closed group of WhatsApp, and we started live lectures with eminent faculties. Now we are having certificate courses online. We have got a very good global acceptance. Last webinar, actually, 906 people are logged in from different parts of the world. And we have got social media platforms like SENADHIPAN Education Foundation Facebook group and two WhatsApp group of 257 participants in each WhatsApp. Now we have two eminent faculty stalwarts in the field of GA surgery. Actually, these people were instrumental in starting the first of its kind GA surgery departments, two institutions, GB Pant and SGPJ Lucknow. You're talking about, oops, the anastomosis leaked by none other than Dr. Adarsh Chaudhary, who is the chairman of GA Surgery, GE Oncology and Bariatric Surgery Institute of Digestive and Hepatobiliary Sciences, Medanta.
Adarsh Chaudhary. I am the chairman of the Department of Gastrointestinal Surgery, Gastrointestinal Oncology and Bariatric Surgery at Medanta Medicity Hospital.
He has done the maximum number of Whipple's operations in India. He has got 40 years of experience in the field. As I said, he was instrumental in starting the first GA surgery department in India at GB Pan Hospital. Then later he joined the Gangara Hospital. Now he is in Medanta. He has got a lot of publications. He is a mentor to many mentors. Even I owe him for introducing me to the surgical scenario of national platform in India way back in 2008 or 10. Thank you, sir, for that. He's a jovial person, eloquent speaker, loved to discuss practical issues. He was office bureau of many associations, including IASG. He was the president of IASG. And for years, he is conducting a session in ASI, which attracts thousands of surgeons to the room. That room will be packed with almost 2,500 surgeons in every ASI. This time, we will be missing that. This the picture was taken when we visited Burj Khalifa. We are on the top of Burj Khalifa. This is the picture taken when I was for a meeting in Delhi. A good speech should be like a woman's skirt, long enough to cover the subject and short enough to create interest. It's not the saying is not done by me. It's Winston Churchill. And we have the moderator, Dr. V.K. Kapoor, who is the who was the head of the department of SGPJ from 97 to 2008. He was actually one of the two people who started the department in SGPJ, and he was heading the unit till 2008 from the last century. He has got 150 original articles published, 6 books written, 6 book chapters written, and he is a guest editor to many journals. I can see that he was a visiting faculty to many hospitals like you in London, New York, Germany, etc., etc.
Postgraduate Institute of Medical Sciences, जिसको हम commonly SGPGI के नाम से जानते हैं, लखनऊ में 1986 में शुरू हुआ. Postgraduate Institute of Medical stage of my career. So
actually,
it was a big
responsibility. The department he was just 30.
पर अब stage of my
he is examiner to Royal College of Surgeons. He was examiner to MCH in AM's, PJ Chandigarh, and many universities. Over to you, sir. Before that, just reminding about the next webinar in SENADHIPAN Education Foundation by none other than Professor David Keown on tips and tricks of laparoscopic liver surgery. And he'll be talking on the technical aspects. All the participants are requested to mute their mic on entry. If possible, kindly acknowledge by renaming your device by yours. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene. Everybody will be given permission to unmute their mic and speak something if they want to speak. If you are on a portable device, please mute your audio and hide your video. And you can contact us with the Gmail ID, senadhim@gmail.com. This is the YouTube channel. All the webinar videos will be available on the YouTube for free. You can visit and subscribe to the YouTube channel. And over to you, Kapoor sir. Now we have got 366 participants in the webinar room. 366.
Good evening, everyone. Thank you, Dr. Baiju. Just one point, somebody in the chat said that probably the audio quality is not good. So if your technical team can look into it from your side, I don't know whether I am heard properly or not.
I think it is the problem with the participant side. I hear everything is okay, sir.
Okay. So without wasting much time, I would invite Dr. Adarsh Chaudhary to make his presentation. For those participants who are not from India, who are participating from abroad, Dr. Chaudhary, after spending a long innings at the G.V. Pant Hospital, which is a premier tertiary level hospital in New Delhi, the capital of India, then he moved to corporate sector and he served in Gangaram Hospital, a very reputed, I wouldn't say corporate, but private sector hospital in India. And now, as was introduced, he's working at Medanta at Gurgaon in the National Capital Region. So Dr. Adarsh, please start your presentation. We are all looking forward to it.
Thank you very much.
Sir, 370 people are there logged in, watching you live.
Can I start? Can I start? Can you see the slides?
Yeah.
Yes, please. Yes.
Okay, at the very outset, I'll make it clear that this talk is only about anastomotic leaks in colorectal surgery. It's not possible and neither desirable to cover leaks from esophagogastric surgery or pancreatic surgery in one talk. I'll be willing to answer questions if you have, but my talk is basically for anastomotic leaks in colorectal surgery. To my mind, the anastomotic leaks in colorectal surgery are a reflection of what life is. And to my mind, life is very unfair. I can understand that the anastomosis that I badly construct there can leak. But why is it that sometimes my best anastomosis also leak? I do not understand. That's one of the questions that always bothers me about leaks following colorectal anastomosis. This is the number of colorectal resections that we perform every year in Medanta. As you can see that the numbers keep rising, and majority of these resections are performed laparoscopically. The reported incidence of leak in colorectal surgery varies from 5% to 25%. And it's the highest in patients who undergo anastomosis between the colon on the lower rectum or the anal canal. Patients who undergo a colocolic anastomosis have a very low incidence of leak. And then we also have a great interest in ulcerative colitis. And in these patients, the incidence of anastomotic leak ranges to about 4 to 7%. But why should we discuss the anastomotic leaks in colorectal surgery? It assumes immense importance because patients who undergo colorectal surgery will not die unless they have an anastomotic leak. So the leading cause of mortality in a patient who undergoes colorectal surgery is anastomotic leak. These leaks are associated with a high incidence of intra-abdominal sepsis. They cause surgical site infections. They increase length of stay. They are the cause for stroma formation. And now there is convincing evidence that there's increased chance of tumor recurrence in a patient who has a leak following anterior resection. Also, once a patient develops a leak, complications start, and these patients stay in the hospital for a long time, and that causes delay in starting chemotherapy, which can affect patients' life. And definitely, there is a impaired quality of life in patients who have leaks in these patients. For example, in a patient who undergoes a pouch anal anastomosis, if there is a leak, these patients have very poor pouch function because the fibrosis occurs in the pelvis and the pouch cannot distend. So patients who have anastomotic leaks, their quality of life gets impaired.
Can I interrupt, sir? Can you make it full screen?
The question that we need to answer is, what is an anastomotic leak? What are the factors responsible for these leaks? We have known that leaks occur, but for last 20, 25 years, we have failed to reduce the incidence of these leaks. What are the principles of managing these patients? So my talk will address some of these issues. Is extravasation of contrast on a CT scan a leak? Is a pericolic or a perirectal abscess a leak? Or a leak is a fecal matter coming from the drains? Is sepsis needing laparotomy a definition of anastomotic leak? Or is it development of an enterocutaneous fistula and anastomotic leak? So this problem has been plaguing colorectal surgery for years because we never had an acceptable and reliable definition for anastomotic leak. So now in 2010, we had an accepted definition of an anastomotic leak, which meant that there's a communication between the intra and the extraluminal compartment because of a defect in the integrity of the intestinal wall. Also, if the CT scan shows that there is a perirectal abscess or air, that should also constitute an anastomotic leak. Because once we have an accepted definition of an entity, then we can all talk in the same language, and then we can find out what is the real extent of the problem. We also have a grading of anastomotic leak, which sadly is not used very often, but it's very simple that grade A is a radiological leak. Many of these patients are all right, they might not need anything. Grade B is a group of patients who have low-grade sepsis, They might do well with antibiotics or maybe a guided drainage. And grade C patients have severe sepsis, they may have peritonitis, they need surgery, and grade C is the cause of death in these patients. Which patients, what factors are responsible for anastomotic leaks? There are some factors we understand, some factors are likely, some factors are proven. We all know that male patients are associated with a higher chance of anastomotic leak, especially when you do colorectal surgery, low anastomosis, which appeals to logic because the pelvis in male patients is narrow. Obesity, malnutrition, comorbidity, ASA score, drugs, they are responsible for anastomotic leak. One of the factors which is shown in all studies to be associated with a high degree of leak is the distance of the anastomosis from the anal verge. Lower the anastomosis, greater the chances of leak. Emergency surgery has been associated with a high chance of anastomotic leak. Patients who have undergone radiation also are known to have a high incidence of anastomotic leak. No doubt, bad surgical technique will lead to leaks. Duration of surgery, fluid overload, and surgeon's experience definitely contribute to causing an anastomotic leak. This is a slide of a patient. I just put it to say that if you have a condition like this, you can see too many fluids have been infused to this patient. You can see the colon is so edematous. You do this anastomosis, it's going to leak. If you have a condition like this, you have two options. Wait for a while, give these patients some Lasix, let the bowel edema settle, or you have to construct a stoma and not do a primary anastomosis. So sometimes it's attention to small details which can prevent the development of an anastomotic leak. This is a patient of ulcerative colitis who received biologicals, azathioprine, and we just did a subtotal colectomy in this patient, and this patient developed a fecal fistula. So the gastroenterologists many times do not realize that the drugs that they give to patients, the immunity goes so low, their healing capacity is so severely affected that these patients develop anastomotic leaks, damage, even with no damage to the intestine. You just do a subtotal colectomy and do an ileostomy. Even then, these patients can have leaks because the bowel is so fragile that these patients can have problems. Interestingly, we give patients NSAIDs after surgery to relieve pain. There is evidence that diclofenac causes anastomotic leak. How does this happen is that diclofenac, which is a COX-2 inhibitory action, causes inflammatory and proliferative pathways are obstructed. Also, in patients who take diclofenac or other NSAIDs, which are excreted through bile, if this bile is given to rats and an anastomosis is constructed, there's increased chance of bile leak. Interestingly, these leaks occur more often in the terminal ileum or proximal colon, because by the time this bile reaches the rectum or the sigmoid colon, the bile has become diluted and is less toxic. So instillation of this bile from the patient, from a rat in whom we give NSAIDs can cause anastomotic leak in a control group also. Interestingly, naproxen, which is also an NSAID, but it is secreted through urine, it does not cause increased chances of anastomotic leak. So we have to understand that drugs themselves may be responsible for causing anastomotic leaks. We know that patients who are malnourished, who have low albumin, who have loss of muscle mass, they have a high chance of anastomotic leak. Till now, we had no objective way to estimate the frailty of a given patient. Now we have realized that a CT scan is a very good index to find out the degree of sarcopenia, especially in patients who have cancer. As we grow older, after the age of 30 to 35 years, all of us will lose about 1 to 2% of muscle mass every year. And by the time you reach my age, you have lost 30 to 40% of your muscle mass. And once you lose muscle mass, your healing capacity gets impaired. So if you study the CT scan of these patients, and you can do a simple test like assessing the psoas muscle area and a psoas muscle density, you can find out that these patients have sarcopenia. And now studies have shown that sarcopenic patients have a greater chance of anastomotic leak. Though mortality has not been shown to be higher in these patients, the presence of sarcopenia in a patient might be an indication that you must cover this anastomosis with a proximal diversion. So observing simple facts, evidences that are there, you can make colorectal surgery safer. We do a lot of things because of our habits, our beliefs. Like I always say, we do not learn, not because we do not learn new things, but because we do not forget old ones. Type or technique of anastomosis, if any anastomosis properly done, is good enough. When I was a MS student, the biggest torture for a student was the examiner's whim of what anastomosis that examiner will do. And they'll always ask, how do you put a modified Gambi stitch inside out, outside in, mucosa in, mucosa out? And now you realize it's all nonsense. Stapler anastomosis is as good as hand sewn. A continuous is as good as an interrupted suture. Whether you use silk, you do PDS, it does not make a difference as long as you follow the principles of surgery. Anastomotic reinforcements in the form of placing omentum, fibrin glue, there is no convincing evidence it alters the incidence of leak. Prophylactic drainage does not alter a leak. If you do a bad anastomosis, you cannot cover it up by putting a drain. You'll have to pay the price for it. Whether you do open surgery or laparoscopic or robotic resections, the chances of leak from colorectal anastomosis remains the same. Whether you do transanal drainage, you do prophylactic anal dilatation, it does not alter the results or the incidence of anastomotic leak. What does help reducing chances of anastomotic leak is definitely proper meticulous surgical technique, adherence to surgical principles. In low anastomosis, in patients who receive chemotherapy or radiotherapy, a proximal diversion is useful. We all know that it may not reduce the incidence of anastomotic leak, but it decreases the chances of sepsis, makes the management of the leak easier. Today is not the time to discuss is ileostomy better or colostomy better. That's a different debate. But a proximal diversion in a high-risk patient makes sense. And definitely surgery in high volume centers in experienced hands has been shown to be associated with a lesser chance of anastomotic leak. I'm more often asked the question, what is your anastomotic technique? I have just one simple technique. In our department, nearly all anastomoses are done the same way. We use a single layer 3O interrupted Vicryl or silk sutures. We are satisfied with our technique, and whatever technique you follow, it makes sense. We do not use any clamps because we believe it is our bias that clamps cause problems. When you open the clamps, there's a chance that these patients may have reperfusion injury. So we do a single layer interrupted suturing, and that gives us the best results. I wish we had an open hall where I could talk to all of you and ask you this question. Which layer is most important in anastomotic healing in colonic anastomosis? There's a term called as illusion of explanatory depth. What it means is most of us believe we understand the world better than we actually do. If I ask you that this is the picture of a bicycle and put the frames, pedals, and chains on it, I can bet 90%, 95% of you will be wrong. And that's what's shown in this study, and that's the various ways people try to put the pedals and chains on a bicycle. What I really want to tell you is that we, especially surgeons, have been doing a lot of things at a spinal level. We haven't thought that what is the basis of what we are doing. What is the relevance of mucosa? What is the relevance of submucosa? What is the relevance of serosa? 1826, Lambert described suturing the serosa in bowel anastomosis. 1881, Czerny said we should suture serosa and mucosa together. And Halstead in 1887 said we should do submucosal suturing. Have you ever thought what is relevant? What should be done? Submucosa is the strongest layer in the bowel. It is the source for fibroblasts. Fibroblasts originate from submucosa. Serosa provides the matrix to these fibroblasts. And mucosa has a great role in maintaining homeostasis. The mucus which we complain about has great role in our well-being, something we do not understand. This is an example. The serosa provides you the framework on which the fibroblasts which come from the submucosa are placed. So the matrix, the structuring is provided by the serosa, the fibroblasts are provided by the submucosa, and the mucosa contributes in its own way in making the anastomosis secure. In experimental animals, if you make them mucosa free, there is a 100% chance of anastomotic leak. So many times when we say mucosa is not important for anastomosis, mucosa has its own role in anastomotic healing. We know that the anastomosis leak in colonic surgery in about 5 to 25% patients. This figure has remained constant for last 20, 25 years. Why has research failed in reducing these rates? Have you ever thought of it? We merely accept it, blame it on various factors and surgical techniques, but there is a lot of understanding which has to go in it. Anastomotic healing is multifactorial. Our research has failed because we have put ladders against wrong walls. We've compared anastomotic healing to cutaneous healing. Cutaneous healing you can see. So we think anastomotic healing occurs the same way. Skin does not have serosa. So most studies have tried to compare cutaneous healing to anastomotic healing. You can see healing on the skin, but anastomotic healing you cannot see. We've always used surrogate markers to see healing. The experimental models use bursting pressure to see the healing of anastomosis. Bursting pressure is not a physiological thing. And with bursting pressures, you only see leaks which have occurred, not which are going to occur. We estimate the degree of collagen by estimating hydroxyproline. Hydroxyproline is an amino acid which reflects collagen synthesis. So you think you estimate hydroxyproline, you estimate collagen. Hydroxyproline merely tells you that the collagen exists. It is not an index of the exact quantification or the quality of collagen. Most of us do not know what is the role of bacteria in anastomotic leaks. And if I ask the audience today, do you know macrophages play a very important role in anastomotic healing? I'm sure 95% of us have forgotten what macrophages are. The problem with surgeons is we only want to be skill strong. We only believe by using better sutures, finer used sutures, by using a 3D laparoscope, by doing a robot, we alter outcomes. Unfortunately, it does not happen that way. Do you realize that the microbiological flora of your intestine is a potential driver of anastomotic leak? This was known in 1955. that if you put antibiotic solutions into the intestine, anastomotic leaks can be decreased. When you do anastomosis to the intestine, it's an injury to the intestine. And that injury alters the microbiological flora of the gut. The toxic bacteria which are damaging to the intestine preferentially proliferate. I cannot go into the details of what happens now, but there is convincing evidence today that patients in whom you see anastomotic leak, the Enterococcus faecalis in them is of a different strain which secretes collagenase. There is convincing experimental evidence that Pseudomonas aeruginosa, which is found in patients who have anastomotic leak, has a different virulence. So bacteria contribute to our anastomotic leak. To make it simple for you, anastomotic leak is partly an infective complication because anastomotic injury changes the tissues around the anastomosis, which changes the microbiological flora next to the anastomosis, and these altered bacteria have a different virulence and they secrete enzymes which damage your anastomosis. Why is the radiotherapy induced rectum more prone to leak? We believe it is because of ischemia. It is not only because of ischemia, because radiation alters the microbiological flora of the rectum, and the newer bacteria have increased virulence and they secrete enzymes which adversely affect your anastomosis. So that's why there is evidence coming today that bowel preparation with oral antibiotics possibly decreases the chance of anastomotic leak, because by giving antibiotics you take care of the offending bacteria. When you prescribe antibiotics indiscriminately to patients, this is what happens, that you kill the good bacteria, the adversely affecting bacteria proliferate. That's why the role of probiotics, good diet helps, because it helps the bacteria which are helping our anastomosis to proliferate and destroying the bacteria which adversely affect us. I know surgeons do not want to listen to these things, but I'm a compulsive teacher and I'm convinced that surgery is not only a technical exercise. You can get excellence till a particular level with your surgical techniques. Beyond that, you have to use your brain. Macrophages are myeloid immune cells. Their unique capacity is to do phagocytosis. They're very good at phagocytosis. And me and you are surviving today in this time of COVID because of macrophages. They give you innate immunity, and wherever there is infection, they go there and destroy the neutrophils which have gone there earlier. The largest pool of macrophages in the body occurs in the gastrointestinal tract mucosa. And macrophages participate in the entire process of anastomotic healing. I've taken this diagram from the Journal of Immunological Research just to tell you that macrophages have two types. One is M1, other is M2. The M1s impair anastomotic healing and M2 improve anastomotic healing. Why I'm telling you is because future research has to be based on these things. If we can estimate the amount of M1 macrophages in a patient early on, we can find out that this patient is likely to get an anastomotic leak. So we do a stoma in this patient. And if there are drugs or methods to improve the M2 macrophages, then we should use them so they proliferate and they support the anastomotic healing. So that's where the future of anastomotic healing is lying. It lies in the complex interplay of various factors, which we as surgeons have to realize. I believe that we need to go towards the unknown. We have very passively accepted that our leak occurs. I wish I can help it. We give various reasons for it. This patient was a smoker, we didn't do that. I didn't take the mucosa in. That's not true. There are factors for which we need to put our mind. We have to do some lateral thinking, read more thinking, improvise things to improve our anastomosis. We have a great habit of, you construct an anastomosis, you want to do an intraoperative prediction of the leak of this anastomosis. Various sorts of tests have been devised, leak tests. You can do a Doppler ultrasound, you can do flowmetry. There is no convincing evidence that any of these tests helps. Yes, there is some evidence that ICG fluorescence angiography, which is now available to most of us, can help us. There is some evidence that ICG fluorescence angiography helps. And this is a very interesting meta-analysis, which I want all of you to read, which has brought out a very interesting aspect of the ICG green fluorescence angiography. Yes, when you do this, you find that a portion of the intestine is underperfused, you have a fresh transaction line, and you do the anastomosis. And this meta-analysis shows when you do ICG, use ICG to see your anastomotic integrity, the vascular integrity, the leak rates in the group were 4% and in the control group were 11%. A second very interesting fact has emerged. It shows that patients in whom you revise the anastomosis, because the initial anastomosis on ICG test showed ischemia, in these patients also the chances of anastomotic leak is higher than the control group, which goes to prove that these patients possibly have something to do with their blood supply of the organ, so they are more likely to leak. So ICG is not only to prevent leak, but is also a very good method to predict the development of a leak and to kind of insinuate you to construct a stoma. This is a very interesting study which was published from Netherlands. We can have anastomotic leaks within first 5 or 6 days of surgery, and sometimes anastomotic leaks appear later. This interesting study, which included 36,000 patients, a large group of patients, and evaluated them. Patients who had early leak were about 2.3%, and 1.8% patients had leaks beyond 1 week. It's so interesting that patients, and it's so intuitive to understand, it appeals to logic, that patients who had early leaks, the cause in leaks in them was surgery-related factors, like they were young, they were obese, surgery was done in emergency, the surgeon did not construct a stoma on these patients, whereas patients in whom leak occurred late, that was because of the disease process. They were sicker patients, they were advanced tumors, they received radiation. So early leaks are more often technical, and late leaks are more often a reflection of the patient's general condition or the status of the disease. A very often asked question is, can you diagnose a leak early? There have been various ways to do that, biomarkers, various things. How good is C-reactive protein? C-reactive protein, we all know, is a marker of non-specific inflammation, that whenever you have inflammation, the body reacts by elevation of C-reactive protein. What is its data in patients who have leaks in colorectal anastomosis? The positive predictive value of C-reactive protein is not good, but the negative predictive value is good. What it means is that if on the 3rd or 4th day your C-reactive protein is not elevated, it is unlikely that this patient has got an anastomotic leak, and this patient can possibly be safely discharged in the next few weeks. You see how simple observations lead to big changes. So it's micro trends which alter things. This very interesting study which said that hyponatremia possibly can predict a leak. A hyponatremia which occurs on day 5 to 7 plus leukocytosis has over a 98% specificity for an anastomotic leak. How do you explain this? It's possible to explain this because once you have an anastomotic leak, you have release of chemoactive substances like cytokines, IL-6, and these cause ADH secretion. And once you have ADH secretion, it leads to water retention and you have hyponatremia. So small, subtle things can tell us that this patient possibly has an anastomotic leak. Once a leak has occurred, how do we manage these patients? The management depends on a couple of things. There are no rules of thumb. What is the site of leak? Does the patient have generalized peritonitis? Is there localized peritonitis? What is the gap from the operation? Is it a free leak or a contained leak as seen on a CT scan with a carefully instilled rectal contrast? And what is the possible degree of anastomotic dehiscence? Patients who have just a small pericolic abscess may be managed with antibiotics. Somebody who's got a just perirectal abscess can be managed by a transanal drainage. Somebody who's got a pericolic abscess might be managed by a percutaneous drainage. Patients who have peritonitis might need laparotomy. And now the endoscopists have also jumped in, and we have a new modality to manage these patients is the vacuum-assisted closure. A database from the American College of Surgeons suggested in 2012 that about 60% of patients will need surgery. That's right, because 60% patients, I believe, when in doubt, it's better to reoperate than to observe. 25% will be managed by a guided drainage, and about 15 to 18, 19% patients will need a transanal drainage, antibiotics, some things like that. If you have a patient who's got generalized peritonitis, and you take up the patient for surgery, patient has undergone an anterior resection, nearly always you'll have to dismantle the anastomosis, close the rectal stump, and bring a colostomy out. Yes, the chances of reversal of this colostomy are very little, but majority of times you'll have to do this because if there's a large rent in the anastomosis, you might have to do it, and this might be the safest option. Yes, if you have a small hole, about a centimeter hole, there is not too much of contamination, tissues are healthy, then you can get away with the suture closure of the site. And if patient does not have a stoma, you must convert a stoma in these patients. And sometimes the leaks are so small, if you're lucky, you already constructed a stoma, you cannot find a leak, then the best thing in these patients is just to do good drainage and lavage and wait. Now the endoscopists have also come in. There is a small subgroup of patients in whom you can possibly put a metallic stent, provided patient is hemodynamically stable. There is no generalized peritonitis. There have been instances where you can manage with an endoscopic clip. There are reports of patients being managed with fibrin glue, but I think they are anecdotal. But yes, you can use an endoscopist with you for an endoscopy guided transanal drainage. There is a lot of interest in the vacuum assisted closure. Yes, there is good literature with this. In vacuum assisted closure, you put cylindrical sponges which are connected with the tube, and it's connected to a constant suction. And with this method, the cavity gradually gets its granulation tissues. There is increased vascularity, and there is decreased bacterial count. And in many patients, the literature has shown that in many patients, the stomas can be saved, and the need for laparotomy can be obviated. The B. Braun brings out the best, I won't say the best, the available vacuum assisted closure device. It can be used only in patients who are hemodynamically stable, who don't have peritonitis, and it's only effective if you used early when the cavity is pliant. Once fibrosis occurs, it is of no use, but it is expensive, and you need multiple sessions. About 5 to 11 sessions might be needed, but in a carefully selected group of patients, the vacuum therapy shows promising results. If you ask me the question, technically how to reduce the chance of an anastomotic leak. I have to do a workshop on teaching young residents how to do a anastomosis to decrease the chance of a leak, my answer will be, I will teach them, first of all, when not to anastomose. In a bad situation, no, but what a great surgeon you are. If tissues are friable, no anastomosis is going to work. You may have a Formula One car. If you drive on the road in Delhi, you can't speed up. There's so much of traffic. So you have to match the trick to the terrain. If a patient is hemodynamically unstable, there is peritonitis, there is ischemic bowel, somebody who has disseminated malignancy, patients on immunosuppression, when you are very unsure about the integrity, the vascularity of bowel, a condition like this, somebody who comes to you with a roadside injury, who's hypovolemic, who's coagulopathic, who has hypothermia, you do an anastomosis in this sort of trauma, this is what you're going to get. The anastomosis is not going to heal. You're going to have a fecal fistula. You're going to have all the problems you never anticipated. So the best way to manage these patients is to do a damage control thing. Don't do anastomosis in compromised circumstances. Exteriorize, come back another day and do the anastomosis. What I'm trying to tell you is that in our life, we are dictated not by our skills, but the choices we make. The choices in colorectal surgery, when you do anastomosis, have to be based very carefully on the available information that you have, the patient's condition, the disease status, the skills available to you, and your scientific knowledge. This is my last slide, I think, and I'll be very happy to answer questions. I purposely kept this discussion in short so that I am able to answer questions. Beju, is it all right with my timing?
Yeah, what an amazing talk, sir. Now we have got almost 459 participants in the webinar room, and lot many are there in the YouTube link.
Baju, my aim is not 459. If even 2 people follow what I'm going to say, if we can save the life of a single patient, but not doing anastomosis in a bad condition, my job is done. I will be very, very happy if somebody's life can be saved.
Yeah, it's just because all the participants are migrated into this webinar room just because of this speaker and also the moderator. Sir, B.K. Kapoor sir is ready for moderating. Sir, please.
Yeah, I would just make only one comment from my side and then take up the questions from the chat and the audience. I think the last part was very, very important. And I cannot agree more with Dr. Adarsh that if I have to talk to residents and young surgeons, then the last part, that when not to anastomose. So if there is any doubt in your mind that this is not a suitable patient or a suitable situation or a suitable bowel for anastomosis, please do not anastomose, exteriorize. Patient with an exteriorized bowel will almost never die because of a bowel related complication. He may die from some other thing, but he will not die. On the other hand, a leak can result in death. So with that comment, I would start taking questions from the chat. Dr. Chaudhary from Indore.
Vinay, just a minute. You know, in the famous book, Art of War, Sun Tzu says the best fighter is one who on the right day runs away and comes back.
So Dr. Chaudhary says that what are the chances of anastomotic stricture following the non-operative treatment of anastomotic leak?
It can happen, but normally majority of times in which a patient you manage non-surgically, the leak will be very small. But it's a theoretical question, because if the leak is so big to cause an anastomotic leak, anastomotic stricture, you will most likely need to operate these patients. But it's very easy to manage these with stents and dilatation these days.
There is a theoretical question that what is the relationship between diabetes and macrophage 2?
Yes, there's a relation. The patients who are diabetics, patients who receive immunosuppression, radiation, in them the function of the macrophage 1 gets over macrophage 2. We really do not know as yet how can we enhance the function of macrophages 2. We know what harms macrophage 2 and induces macrophage 1. We do not know what can improve the function of macrophage 2.
There is a question from Dr. Prasad Krishnan that if you have done a stapled anastomosis and you are now going in to dismantle it because of a major leak, then technically sometimes it becomes difficult. So any tips?
You just need force. You don't need tips. You just have to jack it out. Because when you do it, 50% of your circumference is already gone. The problem is not of unbent. The problem is to close the distal stump. Sometimes it's difficult. You can't reach so down. So it's not, if you can't do it, then there is no great need to close it. It's ideal to close it. Then in that case, you put a anal catheter or something to drain it. But the problem is not to dismantle it. The problem is to close the distal stump. Sometimes it's so small, you cannot reach it in the emergency.
What about antibacterial sutures?
Yes, there is some evidence coming into that, and there are people who believe that it works, but the evidence is very soft. It's not convincing evidence, but there are some studies which say yes. But their role is more in decreasing the role of surgical site infections. Regarding anastomotic leaks, the data is much softer.
And you laid very much importance on mucosa also. So which means that the technique of extramucosal seromuscular bite single layer should not be practiced? Mucosa
No.
should be included?
No. I'm sorry if I didn't make it clear. I also do an extramucosal technique. What I meant was mucosa plays its role by hosting macrophages and by keeping the mucus intact and keeping the microbiome in place. It has no mechanical contribution to the anastomosis, but physiological contribution.
Drains after colorectal anastomosis?
No benefit.
Sorry?
There is no evidence that by drains you can decrease the chance of anastomotic leak. You can only make the recognition earlier, but it cannot decrease the leak. But the funny thing about leaks, Vinay, you agree, is drains don't work where you want them to work. They always get blocked when patients have leak. So
but you would always drain a colorectal anastomosis.
I don't do. Aman, my colleague, who's the colorectal surgeon, he always does it. I somehow don't do, but he does it. He believes that it works better.
No, but would you use a drain or not? In some cases, you would not leave a drain.
In most cases, I will not leave a drain. In some cases, I will leave a drain, but my colleague leaves it in nearly every patient.
There's a question about duration of surgery and leak because of fluid overload.
Yeah. I've already said that surgery will get only delayed if a complication occurs. Otherwise, surgery doesn't get delayed. Surgery gets delayed only in advanced tumors, when you do multivisceral resection or surgery is difficult. So you should be telling your anesthetist to keep the patients dry. I think we should all work on goal-directed fluid therapy these days, rather than giving fluids like we were doing in the past.
There is some report of using hypertonic saline in pancreatic surgery. So do you say that same thing could apply to?
No evidence in colorectal surgery. No special fluid. Only I think we should keep these patients dry for two reasons. One is that decreases anastomotic leak, and second, it prevents ileus. It definitely contributes to early resumption of oral feeding.
Does the use of endosponge increase septic complications?
No, it does not. You only use endosponge if patient has no generalized peritonitis, and there is no evidence that it increases the chances of septic complications. No.
And there is a kind of related question that what is the role of the vacuum therapy in fistula management? Should we give it a try before going in?
It is vacuum therapy works only for if you have early in the course of the disease for the cavity. For a fistula, it is more for the abdominal wall. It helps in a patient in whom you have a difficult abdominal wall reconstruction. You have an open abdomen, you cannot close it. There, a vac therapy works. But once the cavity gets fibrosed, a vac therapy does not work.
Preoperative or intraoperative albumin to take care of tissue edema?
No evidence. Waste of money.
Could you please repeat which situation would be ideal for endoscopic stenting for anastomotic leak?
Vinay, I think it is a very difficult question to answer because I rarely, though literature suggests that, I see very few patients who are fit for that. I mean, you have a patient who's hemodynamically stable, who has no great peritonitis, but patient had some leukocytosis, tachycardia, you do a dye study, a little bit of leak is going into that. In that patients, you can put a stent, but the problem of stents is that the anastomosis has to be higher. They have a degree of migration. So I really do not think that there are great candidates, though the endoscopy literature is there, but in my experience in last 10 years, there may be only 2 or 3 patients which I have sent for endoscopic stenting, because ones who need stenting may not be maybe managed without surgery also. But yes, I've used many for an endoscopic ultrasound guided drainage of abscesses.
Is there any type of stapler which captures the mucosa better, although you clarified that it's not important?
No,
okay.
no, all staplers are same, all staplers are same.
There is a question which is not related to today's talk, but since it is there, any tips to prevent duodenal stump blowout after gastrectomy?
Yes, there are tips to do that. One, the simple trick is do not excessively devascularize the duodenum. If you excessively devascularize the duodenum, and I think when I was a student, it used to be the leading cause of death. Now we rarely see it. We rarely see it. And if you have a bad duodenum, same thing, that if you suppose you're doing a gastrectomy in emergency, duodenum is unhealthy, better not close it, convert it into a formal duodenostomy by putting a Foley's catheter, and subsequently it will close on its own.
So again, the same dictum that if you are in doubt, then don't put any sutures on it. There is a question addressed to me. I don't know why. What is your routine way of bowel preparation for colorectal surgery? I think it's same, that mechanical and antibiotic. Although very recently in our journal club, we reviewed an article where they have shown a large study that bowel preparation or no bowel preparation doesn't make any difference. But I think it's very difficult to directly translate Western literature on bowel preparation to Indian patients where food and bowel habits are different.
Vinay, also when we read literature, we should carefully separate between colonic surgery and colorectal surgery. Because when you do colonic surgery, it's not necessary to do bowel preparation. But when you do a surgery which is colorectal, these two are not similar things. For colorectal surgery, it's different because that's where the risk of leak is much higher. In a colonic right hemicolectomy, you don't need a subtotal colectomy, you don't need. So it is, we have to differentiate what is a colonic surgery, what is colorectal surgery.
There is a question that if you say that leak is an infective complication, then should we not continue use of antibiotics longer?
I never said leak is an infective complication. I said the bacteria contribute to it, and the antibiotics we give to these bacteria don't work on them. When you give antibiotics longer to these patients, you kill them, kill the patient, because they develop extra-abdominal infections. You must read the short study, which is called the short study, which is published, which is beautiful, which says once your duration of antibiotics exceed 4 to 5 days, your extra-abdominal infectious complications become very high.
There is a question about low serum albumin. Agreed, low serum albumin is a factor, whether it is because of poor nutritional status or because of emergency. So if the serum albumin is low, causing bowel edema, then as Dr. Chaudhary said, that you should think of not anastomosing. Extramucosal bites, we have already addressed.
Yeah. Somebody was asking about probiotics. Yes, there is some evidence that if you take probiotics before surgery, you can decrease the chance of anastomotic leak. Soft evidence, but yes, some evidence.
Someone wants to know about the finer points of hand-sewn anastomosis, suture material, bite size.
There is no trick. The only trick is the both ends should be well vascularized. You should do fine. So we use 3O interrupted silk sutures, extramucosal, and we anastomose in the colon in a way that we do the anterior wall first, then we rotate so that both sides are done you can see both sides. And if it's a colorectal anastomosis, we'll always do with a stapler, and we'll nearly always do a proximal diversion.
Yeah, some of the questions which are coming up, we have already addressed, so I'm not taking them.
We start oral feeding next, fluids are started the next day, and most patients are on near normal diet by day 4 or 5, because there is evidence today that by giving early fluids, you do not increase the chance of anastomotic leak.
What about the distal stump? Suppose we have done a proximal stoma and distal stump has been closed and put in and it leaks. How to manage that?
When a majority of times, if you, first of all, one should be, I believe, if a distal stump, it's my bias, it's better to bring it out as a mucus fistula. I don't like closing it, but even if it closes, even if it leaks, majority of times it does not cause problem, but it has caused problem in my life. So if I prefer to bring it out on the abdominal wall, especially in ulcerative colitis, it makes a lot of sense, because many times these patients have bleeding. So from that mucosal thing, you can give some enemas, you can give some drugs. So I prefer to bring it out on the skin as a mucus fistula.
End to end versus end to side, I mean side to end?
If it's anastomosis in the rectum, we will never do an end to end. It will always be the end of rectum to the side of the colon, because it becomes like a pouch. Otherwise, in the colon also, majority of times our anastomosis is side to side, because the lumen disparity is there. So it will majority of times is side to side, majority of times.
And oral antibiotics, which antibiotics?
we give antibiotics for 3 doses, and majority of time these days it is the, I don't want to use the trade name, but we use augmentin majority of times these days.
No, oral.
Oral augmentin. For, are you talking about bowel preparation or after surgery?
Yes, yes, bowel preparation.
Bowel preparation these days, we actually are not, neomycin is not available these days. So we sometimes give these patients cefuroxime, and earlier we were giving patients a single shot of ertapenem, because you know that NEJM article which came, because we don't realize that we earlier used to think that when we give the antibiotics parenterally, they do not reach the bowel. Actually, they reach the bowel then also. But orally these days, even preoperatively, we give these patients augmentin majority of times. It is continued in the postoperative period, and we also add in the immediate postoperative period metronidazole for about 1 or 2 days.
Dr. Baju, there are more than 100 questions.
We entertain one-to-one interaction. If there are more questions, you can ask them to.
You can email them to me. I can give my email ID, and then they can email me to whatever you say.
In fact, we have got a WhatsApp group of.
Okay, I'll join that and I can answer them there if you want.
Yeah, for this topic only, we have got another WhatsApp group. You can join the group and you can give the answers for the questions.
Okay.
And if anybody is there to ask directly, they can raise your hand and we can
raise their hands. You will be able to see them. I think I saw 2 or 3 hands raised in between.
Can you please ask them to who don't? Pramod Samantari. Can you please open? Dr. Pramod?
Sir.
Yeah.
Sir. Rifaximin, whether we should give preoperatively?
I will not be able to answer this question. I have no knowledge about this. I will not be able to answer this.
And regarding the patchy mucosal damage, if you'll see at the time of doing anastomosis, what is your?
That's a very bad sign. A patchy mucosal damage means this patient has embolic phenomena. This is a serious thing, and I think I will never anastomose this patient. The outcome in these patients is very bad.
Okay, sir. Sir. Thanks. Thank you, sir.
Thank you.
Masterly talk. Sir, very masterly talk.
Question.
Dr. Ravi Ramasamy, can you please unmute?
Hello, sir. Good evening, sir.
Yeah, tell.
This is after the post-operative period. The CT by diagnosed radiological leak. How safe it is to start the oral early or late? How long should we wait? Should we repeat the CT and see start oral? Your opinion, sir.
if I can hear you correctly, that you say if a patient has no great symptoms and it's a radiological leak.
Hello.
Is that right? What should we do?
Yes, sir.
My first question is, why would you do a study in such a patient? You only do a study. I think very few of us routinely do a CT with rectal contrast. Majority of us will not do it. We'll only do at the time of the stoma closure. And by that time, nearly 3 months or much more has elapsed. And if that's the situation, we do a dye study. It shows a small streak of dye is going. It's a localized collection. We'll still close the stoma because nearly most of these patients have 3 or 4, 6 months have elapsed. In the second scenario, theoretically, if the patient is all right, has no other symptoms, I will do nothing in this patient. I will observe, and maybe after a period of 6 to 8 weeks, I might do a study, and it still shows a leak. We've had many patients in whom the rectal contrast showed a contained leak, and we did close the stoma in these patients. Their quality of life, or they had no side effects because so much time had passed that the cavity had become localized and it did not cause any ill effects.
In the case without the stoma, that anastomosis is done, the drainage not kept, there are some doubts regarding the leak. So we do the CT, and the CT showed the radiological leak.
If you have not done a stoma and you have not put a drain and it shows a leak and the patient is all right, you still can observe this patient.
Okay.
The overall radiological leaks do not always translate into surgical or interventional outcomes. It's the patient's condition that you have to see how the patient is doing.
Thank you very much, sir. Thank you, sir.
You're most welcome. You're most welcome.
Dr. Ramesh Ardhanari wanted to speak something. Sir, can you please unmute?
Yeah, I have unmuted. Can you hear me?
Yeah.
Yeah.
Yes.
First of all, to Adarsh, thank you for a wonderful lecture. I think you have highlighted all the important points. There was a question which was asked to Vinay about bowel preparation. I think if you plan to go and do an ileostomy before the surgery, then you should do a mechanical bowel preparation before you go for surgery. Because if you don't, and there's a lot of fecal matter between the ileostomy and the anastomosis, that can cause problems, and you want that area to be clean. If you're not doing ileostomy, you're not planned, then you can go ahead and do anastomosis, and you don't really need to do major bowel preparation. But for rectal surgery, like others said, I think most of us, the Indian patients, we tend to prepare because we Indians produce a lot of shit. And so you will often come up with a condition where on the table you have a lot of fecal matter in the rectum. I think that it is good to do that.
Ramesh, also now there is evidence coming back that it is helpful. And
Yeah.
the pendulum is swinging back.
Yeah. So the pendulum has gone both ways, and now from the veteran, see this pendulum is a problem is that it swings between Europe and North America. In North America, they want to prepare. In Europe, they don't want to prepare. And this is what is your training will reflect. But I think many of us in the last 5-6 years have switched to preparation when we were not doing preparation. I think you can also, we must stress that if you've gone in because there is a leak, no matter what leak, right heavy colectomy, colocolic anastomosis, colorectal anastomosis, and you have operated, it is sometimes tempting to put a couple of stitches and come out. It doesn't work. You have to do a defunctioning ostomy. Otherwise, these leaks appear and the patients do badly.
And Ramesh, in these patients, majority of these patients have cancer. They
Yes.
receive radiotherapy, chemotherapy. They do
Yeah.
not tolerate a second hit of sepsis.
No, they do not. So I think you have to do an ostomy and come out. And as you said, there are some patients who require a primary ostomy and then build their health up and then do a definitive anastomosis. I think this is very important. And this judgment, the problem is that most surgeons are close to the idea of ostomy. They say patients don't accept it. I think it's not that patients don't accept it. If you believe that it is necessary, you should tell the patient, look, I believe it is necessary. You don't want it, get somebody else to operate on you. If you are firm enough with that, they will get convinced. The problem is,
and it's very vital for us to have a living patient.
yes.
It's
And
very
so
extremely vital for us to have a living patient.
So you must stress this point, and you must say that if you don't want an ostomy, I won't operate. You go to some other person. Then
I'm sorry I could not highlight these words on the webinar on a yellow thing.
yeah, I know, but I think that this is something that needs to be driven into younger mind, because when you're younger, you think that with a surgical technique you can make up for everything. So you can't. There are certain things that no surgical technique can make up for. That you must learn only with experience. And an intelligent man learns from the experience of others. So what others has told you is an experience of 35 years of GI surgery distilled. And I think you should take that and use that as your starting point and not make the same mistakes that we made.
Is that all, Baju?
Yeah, sir, lot of questions, more than 100 questions are there. I'll ask Dr. Rudra to unmute. Rudra Acharya is an oncosurgeon in Delhi.
Yeah.
Yes.
Yeah, sir, good evening. A very nice talk as usual. So the one technical point is when somebody fired a circular stapler and he did a anastomotic leak test and he found a leak, then what will be your advice?
Okay. The first thing, whenever you fire a stapler and bring it out, is never to change the orientation of the stapler, so that the purse string is a replica of the anastomosis, right? So once you see the purse string and you see that there's a defect in the purse string, the donut which comes out, that can help. Then you do a leak test. Though theoretically, if your donut you can find out, we say you can put a stitch, but in actual life it is very difficult. I rarely do a LAR these days without a stoma. But if I never do a leak test. But if theoretically you ask me a question, if there is a leak test done, I will always construct a stoma. I will try to put a stitch, but I will not manipulate the anastomosis. I will always put 2 big drains in this patient. This is all, but you might damage the anastomosis more by trying to put a stitch and searching for the hole. It's like a hepaticojejunostomy, that bile leak is occurring, you are searching for it. In that process, you damage the whole anastomosis.
Thank you, sir. That is what the message should be given. Thank you, sir.
Dr. Subhash Dadich, I think he is the organizing chairman of the next 2021 ASI. Dr. Subhash Dadich.
Hello. Dr. Adarsh, I hope you remember me. We met recently in Delhi.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So your talk is always most enjoyable. And what I find is these are all golden words from your hard work and your experience, which you did it with your own initiative. It's not what they teach in the textbooks. So every word counts. And like just now, somebody said that 35 years of experience, use it and then start from there rather than do the experiments. And I think if I have to describe you, sir, you are, in one word, you are a careful surgeon. You will not take a chance where the patient is concerned. So what happens, you said that you'll never do a LAR without a defunctioning colon. That I think is a nice idea. Many people nowadays have shifted from that.
It's a bad thing to say always and never. When you say this, means majority of times you will do, majority of time.
That's qualifying it is important. That's correct, sir.
Thank you. Thank you so much.
We enjoyed your talk very much, sir.
Thank you very much.
To many more talks with you.
Thank you very much. Thank you. Thank you.
Yeah, thank you, sir. Dr. Devaji has raised his hand. Dr. Devaji.
I think Dr. Madhu Murli also wanted to know about the relationship between leak and recurrence.
Yeah, it is.
Hello?
Hello?
Yes, yes.
So Vinay, answering that question, that's a very intelligent question. And I think it's related to both. It is both an immunological and it's also because it's spillage of cells. So it's related to both. It's immunological also, and it's, I think, technical also. Yeah, sorry.
Yeah. Dr. Devaji has come. Yeah, Dr. Devaji.
I have two questions. How do you relate preoperative chemotherapy neoadjuvant to the anastomotic leaks?
There is evidence that patients who receive chemotherapy and these days nobody gets only chemotherapy for rectal cancer. Everybody gets
the
radiation
higher
also.
lesions, not the rectal, not the colorectal,
Yeah,
the colonic lesions.
Oh, for colonic lesions, no. For colonic lesions, hardly anybody gets preoperative chemotherapy these days. Preoperative chemotherapy is not the standard of care for colonic lesions. You only do preoperative chemotherapy for somebody who has very advanced disease or things like that. Otherwise, preoperative
Locally
chemotherapy.
advanced diseases.
Oh, but then that's a different thing. For locally advanced disease, also surgery is the first treatment. Preoperative chemotherapy is not the status. But if you have to give that these patients have an advanced disease and you take a call on the operation table about it is, and they have a greater chance of leak because of the disease, not because of the chemotherapy. Because preoperative chemotherapy is not the standard of care for cancer colon.
Okay, thank you, sir.
Thank you.
Thank you. Thank you, Dr. Devaji. Dr. Praveen Bhatia. Laparoscopy.
He called out that he wanted to see you come on the video. And the moment I said come on, he unmuted me and he said we'll start discussion. Luckily, I was already dressed by then.
Dr. Praveen Bhatia, can you?
Yeah. Dr. Chaudhary, an excellent presentation. In your vast experience of 40 years, have you found any difference in managing the leaks in open surgery vis-a-vis laparoscopic surgery?
No, there is no difference. They are both equally, a leak is a leak. There is no difference in laparoscopic or in open leaks in colectomies. It's just the same,
And what percentage of surgery is still open for you today? Colorectal, especially colorectal.
Colorectal, if we do an anastomosis, I don't think it's 99% is laparoscopic. 99% is laparoscopic.
Thank you.
I have a great colleague. I have a colleague with me who's an excellent surgeon. Aman is a great guy. He's one of the best colorectal surgeons in this part of the world. So he does most of it. I take the credit for it.
Good.
Thank you. We presume that your background is not equal.
Thank you. Thank you very much. Thanks a lot.
Do you pay for this or what do you do for this seminar? What is it? What the payment is what?
You make money on this only?
I don't mind. No, Baju and me had a conversation on this. He said he'll pay me in kind. He's already very good.
To VK, Dr. VK Kapoor also.
No, VK doesn't want.
Dr. Faisal wanted to talk. Faisal, please.
Who's that?
Dr. Faisal, can you please unmute?
Yeah.
Yeah.
Yeah, sir. Actually, I want to ask what is your preference in the stoma? Is it ileostomy or colostomy? What is what's your preference?
Okay. Our preference is to do an ileostomy. In elderly patients, we do a colostomy because elderly patients do not tolerate the fluid effluent so much. They go into renal failures and they have issues. So in elderly patients, we do a colostomy. In younger patients, we do an ileostomy.
Yeah, Dr. Thomas. Dr. Thomas Orgis, please.
Hello.
Yeah.
Hi, Thomas. How are you?
Hi, Dr. Adarsh.
Hi, how are you?
Very excellent talk. I congratulate you for that. But I would like to add a few points to that and a genuine doubt also. In addition, if you look at the right-sided lesions and the left-sided lesions, the left-sided lesions leak more than the right-sided, maybe because of the colonic, when they are equal in caliber, size, anastomotic size difference or the caliber difference, plus the mobilization of the colon from the splenic flexure adds more, preventing the stretch. The point what we see notice is it is more of venous issues rather than arterial issues that leads to leak. Because when there is venous congestion, more venous congestion, the mucosal damages or even the serosal damages are more. In addition to that, the point that I would like to ask as an oncologist is, neoadjuvant chemotherapy, I'm a little different opinion with you, is also a standard of care today for the colonic lesions, because there is a dedicated gastrointestinal oncology congress every June in Barcelona, Spain, which I regularly attend. And things are changing for, somebody asked a question, locally advanced colonic lesions. Even for colonic cancer, there is neoadjuvant chemotherapy strategies. And the time that is we are getting in when the tumor is reducing in size, the patient improves in their nutritional status, and the stature improves rather. The only chemotherapeutic drug which may interfere with the anastomotic leak is bevacizumab. Apart from that, the drugs used usually don't create any leaks, rather than it improves the quality of the patient, the weight of the patient will increase, and the resistance power actually increases. Different from the rectal lesions where the patient receives radiation. That is a different ball game. I'm talking about the colonic. So these points I would like to add, because things are changing. Don't tell that every colonic lesions.
I do not agree with you at all.
No problem. I'm telling
no. The purpose of discussion is to have disagreements. That's
okay.
how. What I'm saying is, chemotherapy is not the standard of care as yet for colonic cancers.
That's what I told you. I'm a regular attendee.
So you may be attending. That's okay. That's okay.
There's
also
highlight 1 minute. Gastroenterologist looking at a tumor and a surgical oncologist looking at a cancer may be a little different. But the point I would like to bring in is that there is a dedicated gastrointestinal oncology congress. All the latest papers are discussed. All the latest technical aspects are discussed. The medical part, the basic research onwards, everything is discussed in that congress. So what I would like to bring is, things are changing in different direction to make the locally advanced cancers looking more resectable, more operable.
No, okay, let's not get into the debate. I agree with you that for locally advanced, there may be a place for that. And to say that chemotherapy does not interfere with anastomotic leaks is not true. In all
only bevacizumab.
In all GI cancers, chemotherapy per se may not be responsible for anastomotic leaks, but chemotherapy-induced sequelae might contribute to an increase of anastomotic leak. But I agree with you that in locally advanced cancers, there might be a role, but for a resectable colonic cancer, there is no role for chemotherapy.
Yeah. Technically speaking, if the tumor enters into the serosal level, they are locally advanced. Not extraserosal, even the serosal involvement on a CT or a PET scan, it's a locally advanced disease.
Yeah. Dr. Abhay Dalvi wanted to make a quick comment and leave because he is wanted to attend some another webinar. Dr. Abhay Dalvi. Yeah.
Hi, Adarsh.
Hi, how are you?
It's always very nice to listen to you, especially the punch slides. I don't know how many of them really realize what are those punches that you're giving. So knowing you since a long time, it was a pleasure hearing your this. There are one or two things which I want to ask you, because a lot of discussion is going on the cancer side. and you have a huge experience on ulcerative colitis. So I want you to tell people, because nowadays I'm seeing surgeons who put their hands into ulcerative colitis and try to do all sorts of anastomosis primary. So just elaborate. That's my point number one. Point number two, in coming years, do you really think this endoscopic treatment is going to help in treating leaks, especially in ulcerative colitis? I'm concentrating on ulcerative colitis. And the third thing is rectum colorectal anastomosis. People have to realize that rectum is intraperitoneal, extraperitoneal, and retroperitoneal. It's the only organ which has all the three. So when you come to colorectal anastomosis, just give your pearls of wisdom. So question number one is ulcerative colitis.
What you say is very right. Quickly telling you, ulcerative colitis game has changed a lot in the last 5 years since the gastroenterologist started using drugs which really affect the patient's performance status. So we are doing more and more of 3-stage surgeries because patients come to us, they are sarcopenic, they have severe muscle loss, they can't move around. So we rarely do, less commonly do a 2-stage procedure now. 1 stage is totally out because patients are so sick. So we are doing more 3-stage procedures, and I totally agree with you. This is one surgery not to be done by fly-by-night surgeons. It has a lot of nuances, lot of tricks, and you can make a patient a cripple. This is not a surgery to be taken easily. And because the pouch has to function, it has to reach properly, it has to be good capacity, it shouldn't be ischemic, you have to leave a very short rectal stump, you have to make sure of a lot of these things. These patients are fragile, they get nosocomial infections. And I don't think endoscopists will have any great role in managing these patients in the near future. You talk like a real president of the ASI, you have said prophetic things, and I think rectum has to be taken with a lot of care. It has unpredictable blood supply. You don't handle it well, it always hits back at you. And access is so difficult. And I think laparoscopy has done a great benefit. If there's one place where laparoscopy has helped, is rectal surgery. Have I answered your questions?
Yes, absolutely. I just wanted this message to go across. I could have done it myself, but coming from your mouth.
Ulcerative colitis is a dangerous. To do care, commitment, and compassion for ulcerative colitis. It is not for casual surgeons.
I completely agree. Baiju, I think what I wanted others to give a message has gone across for surgeons that ulcerative colitis is a different ball game. Cancer is a different ball game. So if at all, just because you can do some anastomosis in cancer does not mean you can do an anastomosis in ulcerative colitis. Thank you, Adarsh. You have really done really well, and I'm extremely happy to be a colleague of yours. Thank you so much.
Thank you. Thank you.
Thank you, sir. Thank you. There are a lot of questions, sir. Actually, that because it's very difficult to read out all the questions. More than 100 questions are still remaining. Very difficult to answer all the questions. So I'll do one thing. I'll take a screenshot of all the questions and put it in the WhatsApp group.
And I'll answer them. Okay.
So please join that WhatsApp group. Dr. B.K. Kapoor also, please join the group so that we can have a discussion. The WhatsApp group link is again written in the chat box so that anybody who wanted to ask questions can take that from the chat box and join the group. And the speaker and moderator will be available for the answers. If you Dr. Subramanian Rao wanted to ask something.
What's that?
Dr. Subramanian Rao, all the onco surgeons are there here.
Unmute.
Yeah, unmuted.
Yeah. Thank you, Baiju, for this Sunday evening programs. I actually learn much more Sunday evening than the weekend. And I'll always travel to listen to others, really. Now I did not have to travel. Two things, others. You said you will drain when there is a leak. You will divert and drain when there is a leak. But routine, you are not draining. With what? And you also said when it is necessary, the drain doesn't work. With what profound hope are you draining in the instance of a leak, if you're not draining it routinely, because I drain routinely with the same hope that it would work. In a leak, it works. Even otherwise, it works. It may decrease the sepsis to some extent. Not always, but sometimes.
I agree with you. The debate of drains is ad nauseum. It continues forever. What I'm saying is that there are no absolute rules on it. Once I operate on a patient who's got a gross peritonitis collection, so then I put big drains thinking that they will work. But why I don't put a drain is, like I said, my colleague always puts a drain. I don't do much of this, but my belief is that I have been very disappointed because whenever the leak occurs, the drains get blocked. They never function. They never tell me. And so that's what I'm saying. But I am not saying this is the message for everybody. These are things which are based on personal choices. I'm not saying that you should not put a drain, but what I merely said was that drains do not decrease the chance of an anastomotic leak. Whether you put silk or PDS, drain, interrupted continuous is your choice. And I immensely value your opinion and your experience. And what I meant was that it's my personal choice, but if you do it, it makes a lot of sense.
Thank you, Dr.
And then,
Yeah, he can.
Others, Hartmann's versus anastomosis in cancer. Ulcerative colitis is not something that I'm experiencing. Anastomosis and a proximal diversion, because Hartmann's is much more difficult to close.
I know what you're hinting. I know what you're hinting as a cancer surgeon. You know it. We do Hartmann's procedure. 70% of them never get reverted. You agree? 70% or 80% of them never get reverted. So my general belief is if you do a Hartmann's, it's nearly as good as doing a permanent, because some things happen that these patients never get reverted. You and me both know it. Am I right?
That's such a honest opinion. Thank you very much, Adarsh.
Pleasure.
Thank you.
Pleasure.
Dr. Manash.
Great lecture.
Thank you.
Yeah, good evening. As usual, it was an excellent talk, sir. That was a fantastic talk. But one point I just wanted to get clarified. One point, you told that you do ileostomies in all your LARs. Is it that you meant that all those they receive neoadjuvant, you make them on the ileostomy, and those who you take up upfront surgery, you don't? Or it's a routine that you do for everybody?
We rarely, I think 95% of our patients will have neoadjuvant treatment, less than 5%. If they don't have, we will not do that, but we'll err on the side of doing rather than not doing. What I'm saying.
It's for the neoadjuvant only. You take that. You don't take that chance of.
You don't do that.
Thank you.
So
there are questions in the chat box about pancreatic leak also. They are asking whether we can keep another session. We'll
have another session on pancreatic leaks, Baju, whenever you have time. Okay. Done.
Dr. Ambu has raised his hand. Dr. Ambu, please.
Do you routinely prefer to use?
I think the sound is not.
I cannot hear it.
So, do you routinely prefer to use ICG for if it is available?
What's that? I can't.
No, I didn't also hear.
ICG. Do you routinely use ICG?
These days we are using ICG.
Yeah. I think the net strength is not there with the participant. Can you hear me? Hello, can you hear me?
I can hear you, Baju.
Yeah.
So, is that okay?
Yeah, actually, there are a lot of questions
Can't help it.
on the chat box. We'll be taking this one to the WhatsApp group and we'll be discussing. invite Dr. B.K. Kapoor for the final comments and then by the speaker.
So thank you, Dr. Adarsh, for the presentation and more importantly, the discussion, because I think discussion is more important. And thank you, Dr. Baiju, for asking me to moderate this session. Thank you very much.
Thank you, sir, for accepting my invitation. This is actually an honor for SENADHIPAN Education Foundation. Actually, the next webinar we are going to have is by David Keown, who is the director of liver surgery at Cleveland Clinic, Ohio, USA. He is going to tell us about the techniques of laparoscopic liver resection. So stay tuned on Sunday. Dr. Adarsh Chaudhary, please.
Thank you very much for inviting me here. I absolutely enjoyed being with you, and then thank you very much for all the participants for asking the questions and making this forum a great success. It is collectively when we think together, we agree, we disagree. That's how science moves forward. If everybody agrees, then we'll never be able to go anywhere. Baiju, thank you very much for this effort and inviting me and Vinay here. God bless. Thank you very much.
Thank you so much, sir. We are really honored.
Thank you.
This webinar video will be available in the YouTube link of SENADHIPAN Education Foundation. You can subscribe to that YouTube link. You can have the link. It is written in the chat box. So anybody who wanted to have the WhatsApp link, please message me. I'll be giving that WhatsApp link to you. So already there are more than 150 participants in the WhatsApp link. So you can join the link for further discussion. Thank you all for joining. See you next Sunday, 8 o'clock. Thank you.
Thank you.